Okay, so moving on to our second topic for today, CML from the laboratory. And it's my very great pleasure to firstly introduce you to Assistant Professor Mipsang Lama from Nepal. Mipsang is one of the few real experts in CML in Nepal. He is Assistant Professor in Internal Medicine and has a fellowship in Clinical Hematology and BMT. He leads the CML work in Patan Hospital in Lalitpur, Nepal. Welcome, Mipsang. It's really great to have you here. And our fourth and final expert today, who has already made his mark on the discussion, another giant in the CML field, we have Professor Nick Cross from Southampton in the UK. Nick is Professor of Human Genetics and the Director of the Wessex Regional Genetics Laboratory within the Faculty of Medicine in the University of Southampton, UK. Welcome, Nick. Such a privilege to have you here. So, Mipsang, would you like to share your slides with us, please? And as you're getting your slides up, I'll let the audience know that we'll run this session a little differently to the last one. Mipsang will spend a few minutes identifying the key issues, problems, and unmet laboratory needs in Nepal. And then he and Nick will take turns highlighting key issues or unmet laboratory needs and how those might be addressed. Hopefully, we can again open up to the audience for questions and comments and discuss any issues you like relating to CML from the laboratory. Mipsang, it's all yours.
Thank you, Orlin, for the kind introduction. Good evening, everyone from Nepal. So without delay, I would like to start. So I would like to share with a case. He's a 17-year-old male with a history of early satiety, abdominal fullness, and a weakness. And he has about 70 to 8 kilo weight loss in 3 months duration. On examinations, he's found to be pale, has a huge splenomegaly about 23 centimeters. The counts that we have done show the total leukocyte count of 154,000 per unit liter, which consists of 55% neutrophils, 18% lymphocyte, basophil 2%, myelocytes 13%, metamyelocyte 7%, blast 2%, and band 3%. With hemoglobin of 8 gram per deciliter and platelet is 397,000 per unit liter. So with this information, we were pretty sure, and then we have done a bone marrow aspiration and biopsy. And also we have sent some diagnostic test. Unfortunately, like bone marrow, the reports came out to be like, diluted marrow and suboptimal for definitive opinion. So at the same point, we do a diagnostic tests, but if you say like, do you do it? We do it. But if you say like, do you do it at in-house or maybe in the country, then we do not do it. So we just send this labs outside the country, we outsource this. So with this reports like RT-PCR, BCR-ABL international scale was 0.69% and karyotyping was a normal. So now, like with this information, now we are in a diagnostic dilemma. So the questions over here is, did we lack the skills? Was marrow too difficult? Was it too packed? Or the marrow samples that refined biopsy was not enough sample size? Did we use the appropriate bone marrow needles? You say like maybe the GemCT needle is the needle, but there are various kind of GemCT needles. So maybe the one we are using is not the appropriate that you do use in the West. So at the same point, since this is a clinical eye, was pathologist not confident enough to give this report? So if this diagnosis is in dilemma, we just keep on pointing finger to each other. And with this difficulty now, diagnostic lab again is in a dilemma. So RT-PCR is positive but very low. Karyotyping is normal. And sometimes if you look at my left hand on the slides, I have just shared one report, but this doesn't belong to the same patient. So after 2 weeks, when we have this report, they say like it is non-diagnostic. So now the more chaos condition is created. So I would like to request Dr. Nick to further clarify on how we're gonna proceed because this is the setup that we land up, and then how we gonna solve these issues. So Dr. Nick, over to you.
Yes, hello everybody. So first of all, the normal karyotype. So we know that the great majority of patients with CML have the Philadelphia chromosome or a variant, but between 1% and 5% of CML patients do have a normal karyotype. As you pointed out, Mipsang, the BCR-ABL level by RT-PCR was really very low. It was on the previous slide, but I think it was 0.69% or something. So if we saw that here in our lab, we would wonder if that was indicating the presence of an atypical BCR-ABL transcript. So we would normally do FISH to determine whether there was BCR-ABL present or not in that situation. Certainly repeating the PCR on a peripheral blood sample, you don't need to do another marrow sample, might be advisable. I would certainly be concerned about the quality of the lab results and some of the metrics associated with that. Did the ABL copy number or the control gene copy number, was it sufficient to give, a valid result in that situation? Based on what you've shown, it's not completely certain whether this is a diagnosis of CML or not. But if it was a good lab, I would certainly suspect the possibility of an atypical BCR-ABL fusion. And what you were detecting was a low-level, alternatively spliced BCR-ABL product, and not actually the main product of the translocation. But there's uncertainty here. So I don't think there's a need to repeat the marrow. So if you have FISH or RT-PCR, you can do it on blood. I don't think NGS is going to help you. Consider which MPN query model run other tests. No, I don't think so. I think you want to get clarification. There's clearly a strong hint of CML here, but it's not absolutely definitive.
Thank you, Dr. Nick. So probably we are just, dealing with the atypical type of CML, and then we need to have a FISH for this case.
I think if you do FISH and the majority of cells are positive, you're confident. To get a molecular result for an atypical fusion is complicated in wherever you are. I don't know what facilities might be available to you in Nepal or India to do this.
Well, we could do this FISH, but yeah, I just want to stress that probably this is an atypical case, and we could have done a FISH to have cleansed the diagnosis. So this is what we land up in our, this is not always the case, but then since being a laboratory dilemma, so I just wanted to share this in the group.
Hemant, would you like to comment?
Yeah, I'd like to ask Nick a question. So how do you monitor these patients, Nick, who have these minor transcripts? Do you monitor them by FISH, or do you do the PCR and look only for the minor transcripts?
So in most countries in the West, there are specialist labs who are set up to monitor rare atypical transcripts once they've really been clearly defined as being present. So in the UK, for example, we have 2 labs that are doing that for the whole country. And I think, similarly, there'll be other reference labs in other countries. If that is not available, then FISH is the next best technique. But FISH is not as sensitive as PCR, so it's never going to get down to the levels where you can say there's a deep molecular response. And similar, if you consider stopping treatment, it's never going to be as sensitive. It can't define. If you can do FISH on 1,000 cells, and that may be getting close to major molecular response, but no better than that.
So if no further questions, I think I should get moving. Yeah. So with this thing, I would like to highlight some challenges and unmet laboratories needs in Nepal. So number one, we lack this proper and enough manpower. So since hemat is slowly growing up, still we do lack clinical hematologists, like hematopath, like cytogenetics and a molecular, those who does. So we still lack this manpower over here. We do not have proper monitoring systems. We still do it in the papers. like we are getting up to the, like, I mean, in the IT based hospital management system, but so far, like, I mean, it looks like we have been monitoring into the papers, and then sometimes the papers are lost, it's missing. So we do not have a proper system of monitoring. So frequent monitoring is difficult over here because, like, one is inaccessibility due to the geographical conditions. People will take many days to get to us. So just for even for a single follow-up, people may take about a week to get us and back. And since being a low mid-income countries, financial constraint is a major factor to do this follow-ups. And then even if these have, the patient has access to the hospitals and the finance are okay, then we lack a proper lab setup. As I already stressed, like, we do a basic test, but then for a kind of diagnostic labs, we still depend upon like our neighbor country, India, most of the tests that we do send there. So while doing so, sometimes there is a diagnostic dilemma, sometimes there is non-diagnostic. And while we are doing, sending the, outsourcing the samples get denatured. So there is a problem in karyotyping, like mutation analysis. So all this. And already Professor Malhotra said, like, I mean, there is so many labs and like, I mean, the quality is not assured. So there is a disparity among the all different labs. So why we are having problem with this is because we tend to choose like, I mean, the cheaper labs so that it would benefit the patients. So in doing so, so we are not sure whether to trust this, the reports that we receive. So in doing so, sometimes we have a dilemma in choosing a management. Sometimes when there's a disparity, then probably we land up in whether to move ahead with the same treatment, should we change, or like, I mean, increase the dose. So with the subtle changes, then this kind of dilemmas are that we face every day. So it's not like the test that digital PCR, clonal evolution, next generation sequencing, or maybe targeted gene sequencings are out of questions. Number one is it is inaccessible. Number two is it is very expensive. Even if we did this outsourcing, then that is very, very expensive. So I just want to like run down, since it is known to everyone, but I just want to run some facts about the CML. It's a type of leukemia which has very good prognosis. Life expectancy is as normal as non-CML population. Till the date, we cannot cure the quiescent CML. This is fact as of now, but we can achieve this in a long-term survival. Now we are switching it from achieving a long-term survival to the TFR, treatment-free remission. Just Professor Malhotra just had a presentation. So to have this TFR, we need a constant lab monitoring with appropriate intervention to keep them in a remission, or maybe to keep them into the TFR constantly. So currently, what I assume is the PCR monitoring with a TK as the standard care for the CML patients. And then to have this, like, I mean, there are various guidelines which have laid down the diagnostic workup upfront. So I've just listed the NCCN guidelines to move ahead. And then what it stresses, like it says, like a history and physical examinations with a spleen measurement to have this prognostic score, CBC, chemistries, bone marrow aspiration, biopsy, and morphologically aspiration biopsy and cytogenetic evaluation. And it says like a quantitative RT-PCR by using an international scale and hepatitis B panel. And with this diagnostic test, how we gonna gear the response? That's what you say. So there is like a treatment response that we follow up. Usually it's just like every 3 months for 2 years that most of the guidelines is, but it over here they just have given for a year. So what we gonna get from this slide is like in a 3 months time, we should be decreasing the RQ-PCR by less than 10%. Then in 6 months, probably 1 to 10%. And if it is 9 months, then 0.1 to 1%. If it is more than 1 year, then we should be hitting less than 0.1%. If we are not doing so, then probably whatever that color highlights are shown, so that's we have to assume the resistance and also. So since like a transcript, sometimes I mean, we do not get a transcript. And then in our majority of labs, they do not mention about the transcript. So I just want to highlight some on like the typical type of transcript that we do get, like E14A2 and E13A2 are the major transcript, 95% of that we encounter. There are minor transcripts that we do not care, but this measure the impact of treatment on this transcript. So in a most literature, the type of transcript does not affect a long-term treatment of for a CML if we are continuing to go for a TKI. But patient with E13 and A2 transcript treated with imatinib have lower cytogenics and molecular response compared to the E14 and A2 transcript. Destiny trial have clearly shown like 15% of E2 and A2 relapse compared to 7% with E14 and A2. So Adelaide cohort study also say the patients with the E13A2 BCR-ABL transcript higher molecular response, relapse recurrence if attempted in a TFR, 66% by 35%. So in a short, if we are attempting a TFR, then probably E14A2 transcript appears to be a favorable response. So with these points, I would like to discuss with Dr. Nick, like what would be the impact of diagnosis of for a disease progression if there is a late diagnosis and effectiveness of TKI in that. So while we are outsourcing a patient, samples, we know that there is a denature of the samples. So what would be the viable cell count? If, like, I mean, to remain in a viable cells, is there any pre-treatment to before sending the samples? There is definitely effect on arresting mitosis in the metaphase. So we may escape this high-risk cytogenetics. So any measures to like prevent this? What would be the accuracy of a molecular test that we do? Because like now we say, like, I mean, RT-PCR, the quantitative RT-PCR is the way of going it and monitoring it. So over here, what we do is sometimes we do RT-PCR and sometimes we have this gene expert in-house and we do it the same and then take it as a PCR label. While doing so now, like, I mean, the digital droplet digital PCR is the way of going of a monitoring. As if you are keeping a patient in a TFR, this is the way you have to monitor. That is the one that's it. So apart from this atypical transcript, is there a role of fish in this test while we were monitoring? Because now the goal is to go ahead with the TFR. So will this fish be sufficient, or should we still be saying a cytogenic response is enough? So there are kind of various labs that we have seen, and what would be the standard? What would be the definition of a standard lab? Is the international scale monitoring is enough, or is there any criteria to choose a better lab? So over to you, Dr. Nick.
Right. Well, several questions. I mean, for any accurate test, you have to get the sample to the testing lab as quickly as possible, and without dramatic changes in temperature, without sort of very high temperatures or temperatures that will cause them to freeze, which can happen in some transport. So insulated transport as quickly as possible is really the only substitute. You can have local labs that can process samples, extract white cells and lyse them. They are then much more stable for sending to a lab for RNA extraction. We've certainly done that kind of thing in the past, and that may be worth investigating, but I have to have strict liaison with the lab and test that out. Jerry Radich has talked many times about doing analysis from blood spots, and I think he offers a service for that. The sensitivity for monitoring is relatively limited, but it's very good for confirming a diagnosis of CML. But you really need to have a system to get samples to labs within 48 hours. I don't know how long these samples are taking, but that is the recommendation. And things will really begin to go off quite quickly if that's not possible. In terms of molecular tests, I think having a gene expert system installed where you can run that locally is going to be much, much better than sending samples that take longer than 48 hours to a lab, wherever that is. The gene expert system really works very well. Yes, of course, there are cost issues. It works best where with labs that are relatively low throughput. If you're doing thousands of tests, it really becomes prohibitively expensive. But I would definitely recommend considering the possibility of having a local gene expert in preference to sending samples away. Digital PCR, this is, in my opinion, no, not the test that's going to take over everything. It is easier to run than setting up a qPCR yourself. It is more accurate for low levels disease if it's done properly. Is it more sensitive? Not really. There are several reports saying it is more sensitive, but you're not really comparing like for like. But it may be of value in looking at very low levels of disease more precisely. I think as a general point, you know, with the whole situation of personalized medicine for CML is very advanced. So we tend to be obsessed with relatively fine details about whether qPCR or digital PCR is better. I think in the circumstance you're describing, as I said, local gene expert is undoubtedly the best way to go. Is there a role for FISH? Well, we use FISH a lot for clarification of diagnosis. We really like it because it picks up all variants. For monitoring, it's better than nothing. I would say good FISH monitoring is better than bad RT-PCR or digital PCR monitoring, definitely, but you cannot get down to that sensitivity of deep molecular response, which you really need for TFR considerations. But for general monitoring and possibly to get more information on compliance, there's certainly a role for FISH, but it's second fiddle to PCR-based tests. The last point, I wasn't quite sure what the question we were there, what the definition of the standard lab. I don't know whether this is just related to laboratory quality of testing. It's a very difficult thing, but labs need to participate in external quality assurance and be accredited. That doesn't mean they're going to get everything right every time, but at least it does ensure that they're meeting basic standards.
Hemant, would you like to comment?
Yeah, I'd like to ask Nick. Nick, we are quite aware, at least I'm aware, that you are doing the EQUAS program in England. So can you help, help us set up something like that in India, or can we send samples to you and, you know, kind of cross-check the reports of our labs? Like we have an in-house lab at my present institution, plus we have several labs which we send samples to, and we believe those reports. But, you know, if a consortium could make sure that those reports are correct, it would give the treating clinicians a lot of confidence.
Yeah, so NEQAS, I'm not directly involved with NEQAS, I'm on an advisory group. They send out quality control samples for a very wide range of tests. Certainly, they have done a quality control program in Chinese labs, which I believe was sponsored by one of the drug companies. It does need, you know, just sending samples out, preparing those samples, sending them out. There is a cost associated with that. So, for example, as part of our accreditation process in our labs here, we are required to participate in EQA schemes for every test we do if they're available. It costs us tens of thousands of pounds a year just to participate in these schemes, but that's essential for quality control. I think that is certainly worth exploring with some of the pharma companies to see whether they'd be interested in supporting that kind of activity. And I can certainly help any liaison with NEQAS. I think in principle, you know, they are running BCR-ABL programs. I think they'd be very interested to do that kind of thing, but there is a financial gap which would need to be met.
Raghu, and then back to Mipsang, please.
My question was about the, if you have seen the earlier reports, which were presented just now, what level of quantitative RT-PCR at diagnosis would you say is confirmatory of CML?
Oh, yes. That's a question in the chat. So normally we would expect to see a diagnosis, the vast majority of patients would have levels above 50%. you get some odd cases that are below that, 20%, 10%, and these are relatively uncommon. Certainly to my mind, anything below 1% would start to raise alarm bells that something is odd. There are always unusual patients that break every rule, there are always exceptions, but I would certainly start looking for atypical transcripts if the level was below 1%. Often, most atypical transcripts, they would either have undetectable BCR-ABL by standard testing, or they'd have low levels lower than 0.1% probably. We haven't tested many of these cases because they're so unusual, but we would look for atypical transcripts, and I think it was below about 1%, but it's very difficult to have a hard cutoff. And we would think it unusual if we picked up cases below 20 to 50%.
Would they also respond poorly to the standard treatments, those with atypical transcripts?
No, there's been a lot of literature on atypical transcripts, case reports with either very poor or very good responses, but I think this is very strongly a literature bias to selecting interesting cases for publication. There's been an indication that E1A2, which is the transcript found in Philadelphia positive ALL, predominantly may have a worse prognosis in CML, but the data there is conflicting. So I think the consensus is that treatment should not be influenced at the start by transcript type, although there are certainly some interesting observations. Susanna, I think you were trying to come in about diagnostic levels.
Yes, actually, we have 2 to 3 cases. I just wanted to add that who have, in addition to BCR-ABL, other mutations like CHEK2, or they have in addition an MDS clone. And in these cases, we detected lower levels of BCR-ABL at the time point of diagnosis. And if you treat sometimes, the CML or the MDS part, so the other clone goes up. So I just wanted to add that this also can happen in patients with a low BCR-ABL ratio at the time point of diagnosis.
Yeah, so that's a good point. So very occasionally, BCR-ABL might be acquired late in the disease, and there's an underlying disease. Very, very occasionally, there might be 2 independent diseases. There's a CML clone fighting with an MPN or MDS clone, and one may predominate. You see the BCR-ABL clone, which is relatively small, but you need the full picture to pick up what else might be going on. But these are very exceptional cases.
Mipsang.
Thank you, everyone. So I just would like to move forward. And we have these issues in monitoring, as already stressed in the NCCN guidelines, need for a frequent monitoring, which is not possible because of this inaccessibility, financial constraint. And we also lack this proper diagnosis at the start of the treatment. And also in the monitoring, we do not know what was the level of the BCR at the point of diagnosis. And then it's a kind of haphazard way of monitoring it, no timely follow-up, no timely recording, no recording system. And then, the time follow-up and interventions are totally kind of chaos. Because due to the low economic conditions, we would also assume that the understanding level of the people over here are not that up to the mark. And so, they do not understand the gravity of the situations. So because of that they lack commitments and motivations to come for a follow-up and do the needful. I would also just say that, probably there is a gap in the knowledge. We have to, because medicine is constantly changing, and then we have to update ourselves with the time. And so, while we lack how to monitor, which method to adopt, which is a better way to monitor, how frequently should we monitor, how long and how deep. So this kind of informations may be lacking in some of our colleagues or maybe myself. So because of this lack, we will not be able to monitor the patient thoroughly. And so issues in a mutation analysis and treatment, as I already said, we do not have enough in-house or inside our country to do mutation analysis. Even if we did the mutation analysis, only as few as 20 to 30% will show mutation analysis, as the literatures have said. So because of that, like therapeutic approaches are in a dilemma when there is no mutation information. And we also lack the molecular tests, TK resistance information and a mutation of the information. As I already said, which one to adapt as we were coping with West data and everything. Just now this is a way of monitoring. Now we are saying RQ-PCR is a way to monitor. So now digital droplet, as Dr. Nick already stressed that maybe this is not the one. RT-PCR is the way of doing, but there are literatures which says it has to be a digital droplet PCR to do the BCR-able monitoring. And when we are doing the mutation analysis, which one should we consider? Like conventional Sanger sequencing, next-gen sequencing, or maybe what would be our target gene sequencing, or maybe the whole gene sequencing? And also we are in a dilemma when to do this clonal evolution on the disease progressions. So now the point here in the discussion with Dr. Nick is, if we fail to perform a mutation analysis, which we often do, and even if we did the mutation when there is no mutations, so what is the criteria to choose the best suited TKI in that conditions? And what is the importance of doing bone marrow studies and clonal evaluation on the disease progressions? In cases of CML-CP, do we expect this clonal evaluation? And the common clonal evolution in a CML treated with the imatinib, as this clonal evolution in a CML has a variable outcome with the treatment. So how do we gonna address this? So Dr. Nick, please, over to you.
Yes, well, so to talk about mutation analysis. So if the great majority of patients you're talking about are on imatinib, the real importance here is you're trying to find, is there a biological reason for lack of response or relapse? Is there an imatinib resistant mutation that would clearly indicate that really that would be entirely appropriate to move to a second generation or third generation TKI if appropriate? That's important information, but as you say, it's only a minority of cases. I'm a scientist, not a clinician, but my understanding is that patient comorbidities are extremely important factors in choosing the next TKI. But if you don't do a mutation test, you're not going to have a detailed understanding about whether there might be a compliance issue. It's very interesting to hear that in your part of the world that things are rather twisted on their head, and some patients are very keen to stay on treatment because of skin color issues. But in my experience, it's much more about compliance and actually ensuring that patients are staying on their drug, and poor responses are not due to poor compliance. So I think you said, again, for mutation testing, you would send a sample away. In terms of techniques, you mentioned there are a number of different techniques. In the 2020 European Leukemia Net guidelines, it was quite strongly stated that NGS is better than Sanger sequencing. In the revised guidelines that are in very draft form at the moment, I think we're rolling back a bit from that. So I think high quality NGS and more sensitive mutation detection is good, but you can get a lot of background noise and a lot of misleading information from BCR-able NGS if it's not done properly. And there are a lot of labs everywhere in the world that are not doing it properly. So I think the statement in the revised guidelines is that basically Sanger sequencing is perfectly adequate if quality controlled mutation detection, BCR-able tyrosine kinase domain mutation detection is not available. And indeed in the UK, there are still many labs doing Sanger sequencing for BCR-able mutation detection. I think that's absolutely fine. It has the advantage of picking up higher level clones, not having a sensitive test. You're pretty confident that what you're detecting is real and a likely cause of relapse. All the questions to do with clonal evolution. So this is very clearly in the context of suboptimal responses or relapses, which very much is related to the fact, I think, that patients tend to be picked up in later stages of the disease. in India and Nepal, which is a really big concern. The really big advances are going to come by picking up CML earlier. And I realize that's an absolutely massive challenge, but that really is important. So importance of bone marrow studies for clonal information on progression. I think I'd quite like to ask Susanna at this point, who of course is a clinician, about how she would deal with this particular scenario.
With clonal evolution, exactly, or what? I didn't.
So, I mean, at a patient who's relapsing, showing signs of relapse, and if the level of disease had reached a sufficient level, we would usually do cytogenetics to look for chromosome evidence of evolution. We don't encourage myeloid panel analysis to look at a wider range of genes, including ASXL1, RUNX1, etc. We might do that. I think that will begin to come the norm in any patient who's who's suspected of progressing. But that information, what you do with that information is a lot less clear. And I think that comes down to is, what do you do with the information that's available? What are the options if you do find there evidence of clonal progression or you don't? The number of therapeutic options that are available are relatively limited. Mutation analysis can help to inform which might be the most appropriate subsequent generation TKI. You might find there are very occasional patients with IDH1/2 mutations in transformation that in principle might be targeted therapeutically, but these are rare, and I don't think there's any proof that's the case. So what information is this really giving you? It is confirming that there really is evidence of further disease progression, which is in general pretty bad news. So I'm conscious I'm not being very helpful here. So again, Susanna, patients who are progressing, relapsing, how do you see the sequence of events?
Actually, it's a little bit different. In the first year, it could really be that patients who are in MMR suddenly lose their response very fast, and this is mostly due to mutations. Yes, from a clinical point. And then are these other patients who do not really respond very well, like a primary or secondary resistance. And this is also not only due to mutations or BCR-ABL independent things, but also due to they develop clonal evolution, like Philadelphia, in additional Philadelphia chromosome. And actually these patients are really critical. And mostly, they will not really profit from a change of TKI. So allogeneic stem cell transplantation would be the best for them if available or if young enough. And so the clonal evolution, I think it's really on a chromosomal level, it's really difficult in terms of treatment.
So the importance of bone marrow studies would be to help to confirm clonal evolution, but there are a few positives to bring out of this, aren't there? Clonal evolution is bad.
Yes, absolutely.
So I mean, like, my question would be, like, if there is a clonal evolution, whatever we find, if it is adverse, cytogenetics, that's what we are thinking of, then, like, why do we want to do at this point? Anyways, it's just like kind of a worst prognosis at all when the disease is progressing already.
Nick, do you have a last comment?
The question was why do it?
Yeah, that's what it is.
Yeah. Well, if you didn't see any evidence of clonal evolution, I guess you would be greatly encouraged to change therapy and try and hit the right combination. You didn't find a mutation that was informative. You didn't find evidence of clonal evolution. The battle is still there to be won, I guess.
Yeah, I think. Any more queries on this? Probably this is my kind of last slide. So if there aren't any, then probably we just open to the floor and thank you.
So we have one more question before we move on. We are out of time, but we'll take one more of this one there. Hemant, you had 100 questions.
Okay, so Nick, you're aware of the dried blood spot testing which Jerry does at his lab, and he's done 10, 12 samples for me, and it matches pretty much with the RT-PCR reports, and even the low levels match quite well. Do you think that would be a way out of the problem with Mipsang is presenting, the delay in sending samples? You can very easily extract DNA from a dried blood spot.
Yes, I think it is. It is a potential way. I think the it obviously takes time. I don't know what sort of turnaround time you experience there, Hemant, and I don't know what the capacity of Jerry's lab is to expand. But in principle, it's certainly a very good method for helping to confirm a diagnosis of CML. Certainly, the data that Jerry has showed is that that approach has a relatively limited sensitivity, but it can get down to MMR. But it sounds from what you're saying, perhaps you can pick up even lower levels of disease. If you're taking a sort of hierarchical approach, having high quality molecular monitoring, either by sending a sample away and the sample able to get to the testing lab within 48 hours, or having a gene expert locally, those would be better than sending blood spots. But sending blood spots to Jerry or another lab is certainly going to be better than getting poor quality results from a lab you can't trust, all these samples the majority of the time are simply of insufficient quality. It is getting those samples in a form that can be analyzed as quickly as possible. Spotting them onto a piece of filter paper remarkably preserves the sample. Otherwise, you have to get a sample to the testing lab really within 48 hours in some sort of container that's maintaining a reasonable temperature.
And I think from a clinician point of view, two extremely important messages I'd like to give in 30 years of working in CML. Number one is that if you have a suboptimal response, that the first thing you should look for is compliance. And as Nick also highlighted, that's the number one reason for your patient not doing well. And the second thing which I've learned is that do not react on one PCR report. Every single lab which I have tried and tested, once in a while, they goof up or they have a new kit or they have a new technician, and one report out of the blue really alarms you and alarms the patient. So you have to just repeat that report one time. It's a very, very sensitive test, and you have to understand the limitations of the test and the limitations of the lab. I mean, you cannot find a lab like Nick's lab, which is right 100% of the times. So I think these two things our younger colleagues need to keep in mind. Thank you.
And just to emphasize, we are definitely not right 100% of the time. That's a rule for everybody. You need to look at trends and confirm results before action, unless there's a real medical emergency. It's a complex test, getting good quality samples, extracting good quality RNA, making good quality cDNA. These are steps that are all flaky. They can all go wrong.
Professor Akhil, for one last comment, and then we will definitely close it off.
Yes, ask a comment and then question. Comment is that in Bangladesh, I am from Bangladesh, and we are facing same problem like sample viability issue, because for some testing we have to send the sample in other countries, like routine cytogenetic testing, and so frequently we get no Philadelphia chromosome in cytogenetic, but frequently we get BCR-ABL. There is no problem with that. Rarely we don't get BCR-ABL negative, but if the morphology is highly suspicious of the chronic myeloid leukemia, only in that situation generally we advise for the fish to see any cryptic mutation is there.
The sound quality was really poor, but I think my understanding was if you do cytogenetics and you're picking up an abnormality that's not the Philadelphia chromosome, what do you do? Is that correct? Yes. So we would, so cytogenetic variants of the Philadelphia chromosome that involve 1, 2, or 3 additional chromosomes, and you can usually see a break on chromosome 22 or chromosome 9q34, so the regions of BCR and ABL. We would always do FISH to confirm that that was a genuine BCR-ABL fusion. We'd do FISH or PCR testing to confirm it was a genuine BCR-ABL fusion. I'm sorry, I didn't catch whether there were any additional questions, but these patients are common. I think, the quoted figures are about 85% of CML patients have a standard Philadelphia chromosome, and up to 10% or so have these variants. So they're not at all uncommon. Some of them are very obviously, known recurrent 3 chromosome variants of a 922, but some of them can be really odd.
My other question was that suppose I found another abnormality other than Philadelphia chromosome, like it may be translocation HPNT, or it may be some monosomy or some trisomy, anything. Then how we can decide whether this change is just a part of complex karyotype, additional chromosomal abnormality, or it is an indicator of clonal evolution?
Well, we have a recognized list of additional chromosome abnormalities that are common and recurrent in CML. So I'm just looking, so the additional Philadelphia +8, isochrome 17q +9, the major root abnormalities. So if it's, that is definitely important because they're prognostically significant. There are some rarer things that we know associated with myeloid malignancies, and particularly these 3q26 abnormalities that are associated with a very poor prognosis, loss of chromosome 7, 7q, and some others. So if they're not a recognized finding that we know it occurs in a subset of CML, either at diagnosis or at evolution, it's very difficult to just ascribe any importance to them. I think that's the best we can say. Basically, we understand and have a list of things that we recognize as being chromosome abnormalities in CML. If it's anything else, we don't know the significance.
And I hate to do this, but we are well and truly out of time. Thank you so much, Mipsang and Nick, for a lively discussion. Thank you, everyone, for your contributions. If you put something in the chat, or if you have additional cases or questions that you haven't got to today that we haven't had time for, please email me. I will get your response as soon as I can. And we hope to see you all again soon. The second scheduled South Asian discussion will take place on Wednesday, the 30th of August, same times as today, where the topic will be the wide-ranging challenging scenarios. And there's a great team of experts, as you can see, who will lead those discussions. The third discussion, Wednesday, 27 September, where the topics will be treating CML in children and young people and the impact of CML on pregnancy and fertility. Again, as you can see, what a great team leading those discussions. Please join us for them. I'll email the links so you can register for them soon. And we hope to see you online too. If you aren't already familiar with the ICMLF Knowledge Centre, I'd strongly suggest you go and check it out. There is literally a wealth of knowledge there with many, many dedicated modules on TFR, some of them in development, some of them coming very soon. And if you really want to keep up to date with what's new in CML, then please check out our website and sign up for our ICMLF newsletter. If you do that, we can send you papers of the month and keep you up to date about upcoming meetings and webinars. We can share with you links to summaries of conferences and discussions. And also on the website, you can engage with our interactive case discussion forum, where we take difficult or interesting cases to the key experts in the field for advice or commentary. Or you might like to join some of our social media outlets, Facebook, Instagram, Twitter, whichever you prefer to engage with. Okay, that's it from me. Thank you very much, everyone, for being a part of this discussion. And I really hope to see you all again on 30 August.